This is Dr. Chad Rappaport, and this presentation is on the accessory navicular. Accessory bones are fairly common in the feet, noted to be present about 15 to 30% of the time. These can come in the form of true accessory bones, incomplete fusions, or bipartitions. They're mostly asymptomatic, with the accessory navicular being the most common accessory bone in the foot. It's sometimes referred to as an accessory scaphoid, the os tibial externum, or the os navicular secundarium. The location is typically posterior and medial to the navicular tuberosity. It can be unilateral or more commonly bilateral, and it's typically radiographically silent until the age of 9 to 11, with it being seen about 2 years earlier in females. The classification system for an accessory navicular was initially described by Dwight, but later expounded upon by Geist. Type 1, which occurs about 30% of the time, is a true ossicle within the confines of the posterior tibial tendon. It is completely separate from the navicular and is a true sesamoid of the posterior tibial tendon. It's usually asymptomatic. About 35% of the time, a type 2 accessory navicular is noted, which is an accessory navicular that's joined to the navicular by a synchondrosis. It's typically between 8 and 12 millimeters in size and is divided into two subsets. Type 2A is connected to the navicular by a less acute angle, which results in tension forces across it and makes it more susceptible to an avulsion. The type 2B is situated a bit more inferiorly and is more prone to injury from pure shear forces. Lastly, the type 3, which accounts for the final 35% of accessory naviculars, is joined to the navicular tuberosity by a bony bridge or synostosis. Sometimes this is referred to as a cornuate navicular. It likely represents an end stage of the type 2 deformity, and in general, the type 2 and type 3 accessory naviculars tend to be more clinically significant. As it became evident that there were pathological ramifications to an accessory navicular, of course, theories arose as to how and why, and these included prominence pain, the negative impact that the accessory navicular was thought to have on midfoot mechanics, to trauma to the synchondrosis. As it became clear that type 2 accessory naviculars were most often symptomatic, more precise investigations and theories arose with regards to repetitive trauma to the synchondrosis. Subsequent studies and investigations into the synchondrosis specifically showed chronic inflammation and both osteoblastic and osteoclastic activity at the synchondrosis, with a chronic state of remodeling, and thus it became more accepted that the symptoms from an accessory navicular, specifically a type 2, arise from the traumatized synchondrosis. As the painful synchondrosis became identified as the injured structure in patients who experienced pain, attention was turned to trauma and whether or not these patients suffered a macro trauma or a micro trauma. But studies subsequently showed histologically that there was chronic injury that was unable to repair itself at the synchondrosis, causing pain, and there were forces of tension, shearing, and compression involved. The tension and shearing were attributable to the posterior tibial tendon, and more specifically, the line of pull and of the posterior tibial tendon and its relation to the accessory bone, whereas compression pain was caused on the accessory navicular and the underlying synchondrosis with subtalar joint pronation. Through repetitive microtrauma, these forces initiate an injury to the synchondrosis that's similar to a stress fracture. And their continual actions, in addition to the poor reparative nature of cartilage, lead to, in essence, a painful non-union. So the effect biomechanically of the accessory navicular on the medial longitudinal arch remains a bit of an ongoing debate and controversy, and this is likely related to the association many times of an accessory navicular in the presence of pes planus. Of course, Kidner in 1929 initially described his procedure, which involved an excision of the accessory navicular with a transfer of the posterior tibial tendon to help support the arch. He theorized that the accessory navicular makes the posterior tibial tendon an adductor rather than a supinator, and that it deprives the posterior tibial tendon's attachments to the cuneiforms and metatarsals, and therefore weakens its ability to support these structures. This was supported once again in 1965 by Leonard, but these improvements with regards to biomechanics and in the arch were mostly observational. Subsequently, there was a slew of studies, some of which are listed here, which ultimately disproved the Kidner procedure as one that improves the clinical or radiographic presentation of the arch, and ultimately became accepted that pes planus can contribute to the symptoms associated with an accessory navicular, but an accessory navicular does not cause pes planus. With regards to the clinical presentation, an accessory navicular is typically symptomatic more often than not in childhood and early adulthood. The pain is localized immediately, where there is prototypically edema, erythema, and a symptomatic palpable prominence. Girls and women are much more commonly to be affected than boys and men, and in about 50% of the cases there's a concomitant pes planus deformity. The presentation clinically of these patients differs depending on their age, where in children typically have symptomology and pain with pressure over the medial prominence, which is activity related and not attributable to any type of trauma. Conversely, in adults, there is more of an acute onset. These tend to present more after a post-traumatic event, particularly an eversion like injury to the foot. And in adults who have an accessory navicular, it's been theorized that these patients have decreased posterior tibial function. As far as imaging is concerned, plain films are obviously the most commonly obtained types of imaging, followed by MR imaging, particularly if there's concern about the condition of the posterior tibial tendon. Bone scan I included here for historical purposes, and ultrasound is a developing modality that can be used to help assess the condition of the posterior tibial tendon. As with most conditions, a course of non-operative or conservative treatment is usually initiated, which can include any one of the following: activity modifications, padding of shoes, non-steroidal anti-inflammatories, corticosteroid injection, and in severe cases, cast immobilization. These have all proven to be minimally efficacious with regards to long-standing or permanent relief. With regards to surgery, as mentioned initially in this presentation, type 1s rarely require surgery, but when they do, a simple excision is usually efficient. Type 2s are the most likely to require surgery, and it's typically comprised of a Kidner procedure with what to do with the adjacent posterior tibial tendon, dependent on the patient and the surgeon's preference. Excision should, however, include the entire synchondrosis and any navicular prominence. In some patients with a biomechanically neutral foot, attempts at reducing symptomology from the synchondrosis by way of RAF, or an arthrodesis, if you will, of the synchondrosis has been detailed in the literature with good success. In the patient who does not have a neutral foot or has a pes plano valgus foot, the Kidner procedure and its variants are typically coupled with the typical procedures that we use to correct a flexible flat foot deformity, which would include a calcaneal osteotomy, an Evans procedure, a cuneiform osteotomy, and an arthroresis in pediatric patients, although I personally have no experience with this procedure. Type 3 naviculars typically require nothing more than bone resection. The resection should be performed such that the medial border of the navicular is flush with the medial border of the talus. The post-op care depends on the procedure or procedures that are done at the same sitting. Generally, all these procedures are reliable and successful with low rates of complications. In conclusion, the accessory navicular is a common finding in our patient population. The type 2 accessory navicular is most likely to be the type that is symptomatic and warranting treatment. Non-operative or conservative treatment typically fails, and so many of these patients will undergo some type of surgical procedure with generally reliable and good results. Thank you.